Back to Practice has been made possible with support from Allergan and Novartis. We'd like to thank our sponsors for their support of this programming.
Hello, everyone, and welcome back to New Retina Radio, Back to Practice. Necessity is the mother of invention, and today we are going to be focusing on technology and COVID-19. Which technologies are stopgaps and which will be permanent? Joining me again for another episode is going to be Dr. Maria Berrocal from Berrocal and Associates in San Juan, Puerto Rico. Joining us from the University Hospital in Bordeaux is the head of ophthalmology, Jean-Francois Korobelnik. And we also have Dr. Manish Nagpal, who is a senior consultant for the Retina Foundation in Gujarat, India. Thank you all for joining me today for this. As we start, it is August 7th, 2020, and globally we have 19 million cases of COVID with 715 deaths. In the United States, we have 4.8 million cases with 160,000 deaths. In India, we have 2 million cases with 41,000 deaths. And in France, we have 231,000 cases with 30,000 deaths. Maria, let's start off with you. How are things in San Juan now?
At the beginning, we had a very low rate of cases because we had a very strict lockdown. But then in the past about 3 weeks, our cases have started to increase with the relaxation of the lockdown and the tourist season starting. So now we have a lot of cases are rising and deaths are increasing, not to the levels of many of the states. So now we are being extra cautious with everything, and in the practice, cases have gone down, people coming in because they're more afraid. So I think we're going to see a waxing and waning, of the way we function until everything stabilizes.
Any thoughts on reinstituting a lockdown there, or are you pretty far away from doing that?
Well, no, I don't think they're planning on that, but we still have curfew from 10 p.m. until 5 a.m. every night. And bars are, alcohol is not served after 7 p.m. And on Sundays, there's like a lockdown of activities, and beaches are to be used for sports only to avoid, gathering of lots of people around. We're pretty densely populated, so that is an issue. On the upside, we don't have to worry about winter coming and people being inside all the time, because we have a tropical weather all the time, which is very helpful because people can be outside, and gather outside. So I think in that sense, our case count is lower. And we have instituted masking has been around since March, and everybody except, foreigners are really, really strict about masking. So everybody wears masks, which I think has been very helpful.
It's very interesting. So are foreigners not required to wear masks, or is it just a cultural difference?
I think here people really, we have we are less individualistic in the sense that I think, we don't have to think about my rights and this and that, that is not an issue. I think everybody, we've been through hurricanes, we've been through a lot of natural disasters, and everybody has to band together to make things, work. Like after the hurricane, we were without electricity for a very long time, and everybody you would help your neighbors and everything. So the collective good is actually very strong in the culture. And I think that is, it's not just me and what I want to do, it's really what is best for everybody. And here we have in many families, like in many places in India, it's the extended family. So you live very close to your grandparents, and elderly people and young people live together. So I think it's even more relevant to be more wary about being contaminated.
Manish, Maria alluded to India. How are things in India, one of the more affected countries in the world?
Well, in India, we went into a very early lockdown, when just COVID just came into India, and everybody thought that it's the best time to have a very strict lockdown. And we did that for about 2 months. But the thing was that by the time we came out, COVID was still there. And as they started opening the lockdown, everywhere the numbers went on increasing. And the way the pattern has been, every city which was very good earlier slowly has been affected much more, and those cities which were affected much more in the early phase are slowly now going down in numbers. So it seems that every place has to achieve a certain high and then only it starts to go down. So we have numbers all around, although the death rate is not comparable to what happened in Italy or the US death rate. Fortunately, a lot of them are asymptomatic, low symptomatic, and not so many are on ventilators, but the numbers are increasing.
You know, Manish, India is just such a massive country as far as population is concerned. Is there enough testing in India? And then how are the healthcare resources? Are hospitals being overwhelmed, or are hospitals keeping up with things? And then the final question is, such an astoundingly low death rate. India should be congratulated for what they are doing. How are you achieving that low death rate?
Yeah, so we are ramping up testing continuously since the testing started. But of course, our numbers are nowhere close to what the West is able to test, but they have been gradually increasing the testing all over just to make sure that they reach out to every aspect of the city and go on with it. But when you talk of the death rate, I'm not sure if we are doing something really right and not wrong that we have a low death rate. It's probably something as a predisposition. Maybe, in the beginning, people said we have immunity partly because of the BCG vaccine, and maybe we have a hotter climate, and so many things came up, but none of us knows why, because we have a huge population, as you said. We have socioeconomic issues. People are crammed up with each other at a lot of places. There are slums. We have all the things which are an absolute recipe for a disaster, but somehow it's not at that level. So we are fortunate for some other reason like genetic or immunity or something else.
Excellent. Jean-Francois, France has done astonishingly well as far as managing COVID. Why do you think France has done better than places like Italy and Germany and UK?
Well, I think that we had bad luck and good luck. There was, at the beginning, there was a very big, very important cluster in the east of France with thousands of cases. But on the west of France, there were very few cases. And still we have very few cases. We have in the west of France, we have a lower rate than in Germany. So thinking about the country as one unit is not completely appropriate. I think we have to think about area in the country. We had an issue with masking at the beginning because they were not available. So the government didn't say wear a mask because there were no masks, or they say wear a surgical mask, but they didn't recommend a tissue mask. Now things are going much better. We have masking for everybody, and the lockdown is over. And we are now with a stable rate. The thing is that the number of new cases diagnosed is increasing since the last 2-3 weeks without an increase in intensive care unit patients. So one of the simple explanations is that maybe the new cases are young patients with less comorbidities and who do mild, moderate COVID instead of the elderly that were very hardly hit at the beginning.
Excellent. And before we get into the ophthalmology specific things, one more question for you, Maria. Since you're in a tropical climate in San Juan, do you all have a flu season, or is that not such a big deal in Puerto Rico?
Well, we do have a flu season, but it's not, flu is not as big, we don't have as many deaths from flu as places in the US, and it's not so bad just because, we're not locked inside. So contamination from people just being held inside all the time is not an issue. So I think that's an advantage that we have. And I see that, I worry about winter coming in places, that have cold weather just because people will be cramped inside.
And I can just say in the US, we have such a struggle here because we have different parts of the states that are affected differently. And I think early on, we locked down the entire United States. when things were really bad in New York and in Boston. And, and now it's really hard to convince people in areas that are hotspots that they need to really do the right thing. We also have a tremendous amount of political strife and so much disinformation through social media about whether masks work, whether they don't work, is COVID real, or the death rates real. It's just astonishing. Some of the freedoms that we have here are actually detrimental to what we're doing. And it was very interesting to hear Maria say that Puerto Rico has more of a community attitude than we do here in the States. It's very individualistic here and very focused on individual freedoms. And that right now is working against us, I must say. Maria, in your clinics, have things changed over the last couple of weeks since we last talked?
Yes, things were, our cases were really, really low. So when we came out of lockdown, cases were beginning to pick up, and then they eased the restriction of only doing emergent cases. So we were able to do as many elective cases as we wanted, as long as patients had testing and we had PCR available readily for everybody. So things were getting more normalized in that sense. But since the cases have been increasing in the last couple of weeks, and now, with the upswing of cases in the States, we are not able to get as many reactives to do PCR testing. So that is more limited now. So we get a lot of case cancellations because of the lack of PCR testing. And also, I started in the last couple of weeks, so many cases were coming in, I started not seeing some patients that were not emergent. So I go through the lists, and if it's someone who's 90 years old, who is high risk, and just wants to come for their yearly appointment, I call them up and I tell them, look, let's postpone this, maybe a month or two until the cases are lower, because I really don't want people to get, to get contaminated, even though we take all the precautions, everybody's masked, we have all the chairs by, 6 feet, they wait in the car. So we're still doing all of that.
Manish, in India, how are things from a retina standpoint? Has this affected your clinic significantly? Describe to me what you're doing differently.
Yes, so when the early lockdowns began, we started working twice a week and just taking in emergency cases, detachments and endophthalmitis or something like that. But we kind of refused most of the patients. A lot of it was done on the phone by trying to find out our old patients from the case files. We would just call them and describe them that this is not an emergency and it's best to wait. So initially we started off like that, twice a week, and then we kind of started working just a few hours in the morning every day. And even as we stand today, we work from 9 to 2, just the first half. In a few weeks, we will start working our second half as well. But through this whole time, in the first 2 months, we did only emergencies, but slowly we have now, over the last 2 months, have started taking in planned cases of all sorts, although that's a very small number. Patients are not willing to come as well, as long as they're planned cases. So it's a slow process. We are working at about 45% of our work at this stage, as I talk to you, yeah.
And how about your referring doctors? Are they seeing a similar level of patients, or are they totally shut down? Your ophthalmologists, your optometrists?
Which ones?
The referring doctors, your ophthalmologists, your optometrists.
Yeah. So this is for when you ask for retina, this is what is about going on, because retina cases are still there and we work at about 45-50%. But the cataract and planned corneal stuff, planned cataract stuff is extremely low. I mean, the referring doctors from that whole pool, they are not operating much because most of those are planned surgeries, and that's why that work is much slower. It's at 20-25% only. That way. Yeah.
One of the things that we experienced here when we went into shutdown was that we continued to work just like you did, and we went down to about that 45% level. But our referring doctors shut down, and that gave patients with emergencies, new patients, no avenue to get into us. They didn't know they should call a retina specialist. They would just, new wet macular degeneration or retinal detachment, and they would call their local eye doctor, and the message would be, we're closed. And so then they would sit for, 4 weeks with a retinal detachment. Are you worried that that's going to happen in India?
I don't think that shutdown, I mean, they've not totally shut down in that sense. So they're still looking at patients. So we are not getting that set of patients which you're talking about, that they come to us as a first line. In fact, that whole cycle has slowed down because they are seeing those patients and sending whatever is retina to us, but not necessarily anything which is planned. And their own work from which they usually make complications is not happening.
Yes.
So are you getting COVID testing prior to all of your surgeries, Manish, or are you deferring COVID testing?
No, we are not doing it for all our cases. We are doing it for any case which requires a general anesthesia, because our anesthetist needs to be protected, and so they need it as a requirement. But all our local cases, we are not doing it as mandatory unless there is a symptom or something that we are worried about, and we get it done. But as I speak, I do know of a few colleagues elsewhere in different cities who have started this practice recently. And in just last week, somebody was telling me that we've started doing it for all our cases. So it's a varied pattern, and maybe we may switch to something like that as the testing becomes much more easily accessible. But as I speak, we are only doing it for general anesthesia cases.
And, you know, Maria alluded to this. Here in the States, we are doing COVID testing for most of our non-emergent cases, for all of our non-emergent cases. And it just adds a layer of complication in getting that testing and getting the test results. And frankly speaking, in some areas, we're having a difficulty in getting the very rapid tests. So some patients have to get tested a week before their surgery, which makes scheduling just a logistical issue. Jean-Francois, in France, how are things for you as far as practice is concerned? Are you back up to 100% of your normal volume? What things are you doing differently now than you were, say, at the beginning of the pandemic?
Well, during the lockdown, we reduced the activity to about something like 30% of what we did before. We selected the cases that needed to continue treatment, like wet AMD cases, of course, retinal detachments, and we canceled all what could wait, like cataract surgeries, some injections for DME patients. And the lockdown lasted 2 months. We opened mid-May, and now we are going back to not normal. We are about at 70% of our previous activity. And we'll discuss that later, I'm sure, but we changed things to make the duration of the stay of the patient in the clinic much shorter. And exactly as Manish said, we do all patients under local without testing, and we do all patients under general anesthesia with testing done 1 or 2 days before the surgery. And this is mandatory. The anesthesiologist really requires that. Otherwise, the patient is just canceled. So we switch many patients from general to local, and it works pretty well, in fact.
And obviously you're doing retinal detachments, macular holes. Are you doing macular holes and epiretinal membrane surgeries and everything?
Well, we canceled that during the lockdown, but now we are doing them again. Well, we are asking them if they want to have surgery or if they want to wait for more months. But as the pandemic is lasting, saying, okay, we'll do that in 2-3 months when things get better, I'm not sure that things will get much better in 2-3 months. So we ask the patient, do you want to have surgery now or do you want to wait? And it's up to them. Some of them wait, saying, well, I'm okay, finally, I can wait. And some others are really asking for surgery, and it's okay. I mean, it's not so bad. The issue now is transportation, because in the clinic, we are extremely careful, as Maria said. In their place, they are okay, but transportation can be a time when they get contaminated. So they are very careful, and we try to be very careful.
And is that because most patients take public transportation to get to and from the hospital?
Well, they may take public transportation. They may also take a car with someone driving them. And the driver may be family or a neighbor or a company, and then they feel they are exposed. And some of the drivers, they don't want to work at the moment. They need the money, but on the other end, they don't want to work because they don't want to be exposed with what they think are sick people, sick patients. So it's getting better, transportation now, but it was very complicated during the lockdown, because the lockdown was extremely well followed, and everybody was really at home, and so the drivers were at home. So for the patients that had to come, they couldn't find the driver to get them there.
And you alluded to this earlier, but what sorts of things are you doing differently to keep patients safer, to increase the PPE and increase the social distancing and those sorts of things?
Well, for those who come without a mask, masking is mandatory in the building. They come alone. We ask any relative, anyone except for children, anyone to wait outside. And we reduced the things that we were doing previously, and we may discuss that later, but we have a kind of straightforward line for the patients to be taken care of, and they spend much less time inside the building as compared to what we did before.
And how are you achieving that on a workflow basis? Are you doing more OCTs and less dilation, more imaging?
Well, to go in the details, we very often, in the retina practice, very often we skip visual acuity evaluation. We used to do a refraction at every single visit for AMD patients, for example. We don't do that anymore. We do that, we decided to do that between once and twice a year, and that's all. And in the meantime, we do the OCT. Depending on the physician, some do fundus photography, some don't. And based on the OCT and the comparison with the previous exam, we decide if there is disease activity or not, and then we modify the next appointment, because we do almost all our cases are on a treat and extend regimen. And some of them, we switch them to fixed for a while, but now we are back to doing OCTs at each visit to try to customize the duration of the treatment.
Are you dilating patients at every exam, or no dilation for many of these patients?
No dilation, no. Too much
and
time.
What about pressure measurement? Are you doing pressure measurement as well, or just coming in an OCT and treating?
Well, we measure the pressure for patients receiving steroids, but for anti-VEGF treatments, we don't. No.
Gotcha.
Of course, we have glaucoma patients. So for the glaucoma patients, it's a different story. But talking about the retina clinic, no, we don't.
Wow, very good, very good. Manish, what are you doing differently now to ensure that these patients are seen in a timely and safe fashion?
Yeah, so when they come in at the clinic from outside, we used to earlier do a pre-screening, tonometry, AirPuff1 screening. So now everything is restricted to only those where we know patient has previous history of glaucoma, and we do the AirPuff tonometry as far as possible. And but now we do it in selected patients only after the patient has been seen by us, and if we feel there is a need for a pressure check, we do it. I don't have patients sitting on a slit lamp unless I really suspect something and I need to have them sit down. Even on an indirect with a 20D, I'm doing a cursory screening. I'm not doing a spiral depression and looking at far peripheries in most of the patients. And I would just do a gross look and derive at a diagnosis. And we would do OCT and OCT angiography sparingly wherever indicated, but I'm not doing FAs or ICGs as much as possible. Extremely essential, then I would do it, but not as a routine. And also we use wide field imaging, which helps us see the periphery and also document it. If there is a lesion, we like to get one of those photos done so that it's easy for us to establish a baseline as well as explain the patient, rather than trying to look for it and spend time on the patient trying to document it ourselves.
And do you repeat that at every visit, or do you repeat it at certain intervals in certain patients as far as the wide field photography is concerned?
Sorry?
Do you repeat the wide field imaging at certain time frames, or do you just do it at baseline?
No, at baseline. Then only SOS if it's required on a follow-up. If you've treated a hole or a lattice or something in the periphery, and then we just want to document it well, I would do it at the end of a month. But otherwise, only as a baseline.
And as far as treatment is concerned, are you treating more often, doing more treat and extend? How has this changed your treatment parameters?
Yes, so we don't now do OCTs as a routine to look for changes for us to decide whether to give an injection or not, except for those who have come the first time, and or we are trying to look for a recurrence in a patient who's already under treatment since a long time, or if there's a symptom we can't explain. But otherwise, they're all put on regular regimes. Yeah? 3 injections to begin with, and then it goes on to treat and extend or PRN based on the type of patient that we have. If it's an AMD patient or a diabetic patient, it would vary on that.
And Manish, do you find that you're doing more laser for your diabetic patients than you were previously in case those patients can't come back?
The PRPs, you mean? Yes. Macular laser, I'm not doing so much. In fact, I'm trying to avoid. I would rather do an injection and not do a macular laser in this period. But PRPs, yes, we are doing as often as we can on these patients because, as you said, we do them more often.
Maria, you had a great debate at the most recent Berrocal meeting about early surgery, and you can convince anybody of anything. You talked about early surgery, but let's talk a bit about PRP first. Are you doing more PRP now than you were in the past?
Well, I really never, I have never adapted the anti-VEGF for patients that have diabetics with proliferative disease, because we know that the absentee rate for visits is over 25%. It's 25% in everybody, but in diabetics, it's close to 50%. So I always worry that they're gonna get neovascular glaucoma. So if I only use the anti-VEGFs more for the macular edema, those I treat always with anti-VEGF, but I always do PRP on my diabetics, and I explain it to the patients. I've never had anyone who chose the monthly injections versus, the PRP. I offer it to them, but I also explain, the problem with them not coming in. So I've always done a lot of PRP in that sense. But the injections for edema, when we think about patients that may not need to come in as frequently, well, it would be those versus the AMD patients, the macular degeneration patients. The way I have streamlined them is that if they're in a set regimen, I don't do OCTs at all the visits, and I may not do visions at all the visits. So I usually alternate, one visit with OCT, one without, and the like, just to get them in and out as quickly as possible. I also use wide field imaging a lot. I do it at every initial visit if somebody comes in complaining of floaters and the like, and that is very helpful, in managing some of these patients.
Who specifically do you get the wide field imaging on? Do you get them on every patient? Do you get them mainly on your diabetic patients, patients with retinal detachment or peripheral pathology? How do you do that?
Well, I really like getting it on all diabetic patients, all the patients that come in with, hemorrhage, patients that come in complaining of floaters. I really like, and it's very helpful to show them what is actually there. If you're a patient and you're seeing 20/20 and somebody tells you that you need laser because you have, a break in the periphery, it's very helpful to actually show them. And it saves you time as far as doing scleral depression and being a long time with the patient. You still have to do it to really see, the periphery in some cases, but it streamlines. It streamlines. I also really like wide field imaging angiography. I think you see a lot of ischemia in the periphery that you may miss. You have some eyes that look pretty good, and then you do the angiogram and you see neovascularization, subtle neovascularization in the peripheries.
And along the lines of treatment, Maria, are you doing more treatments now in patients, doing more treat and extend? And also, as you alluded to earlier, are you doing more surgery on some of these diabetic patients in this COVID timeframe so that you can just get them taken care of and not have to worry about them?
Well, yes, I'll start with the last one. When I see a diabetic that comes in with a vitreous hemorrhage and he's younger, I always offer surgery. I think, especially if they have significant disease, I think as I have shown, some of these cases can progress very, very quickly to a traction detachment. So I think it is very helpful to actually do that. I of course do laser during the surgery. It's not just vitrectomy. You do a vitrectomy, remove the hyaloid, because once you remove the hyaloid, you basically eliminate their chances of them developing a traction detachment. So in a sense, it's sort of like a long-term curative procedure. I do treat an extent for the anti-VEGFs, but the ones that are set, I have some patients that I may inject every 3 months, or that is like the longest that I actually go with them. And they just come in, and I, in those, if it's every 3 months, then I do an OCT just to make sure that they don't have increased activity. But the ones that actually require the injections every month, I don't usually OCT them at every visit. And the same with pressures. I am just doing pressures in many of the patients. We use a tonopen, during the COVID for everybody, but only on new patients and patients that have a history of glaucoma. Patients that just come in for injection and have been stable, I don't see a need to do that in this situation.
So what I'm hearing here more and more as we focus on technology is basically that most people are relying on OCT as their primary means of evaluating these patients, and then the valuable role of photography, specifically ultra wide field photography with angiography in the diabetic patients to help us diagnose these patients, explain to these patients what's going on, and establish a good baseline. And that actually may be a little bit different than what we were doing before. Jean-Francois, in the operating room, are you doing anything differently, utilizing any technology differently in the OR?
No, not really. We were very careful before, and we are still very careful to avoid endophthalmitis, of course. And the only thing that has changed is the protocol when we need to do general anesthesia. That's the big difference. In that situation, everybody is out of the room. There is in the room only the patient, the anesthesiology nurse, and the anesthesiologist, only 3 people. And they do the general anesthesia. Then we wait for some minutes so that the air in the room is cleaned. And then we get in, we do the surgery, then we go out, and then the patient is taken care of and is moved out directly. So it's time consuming. And of course, the anesthesiologist is wearing a protective screen above the mask and all the PPEs that we know. So they are very careful. And as I said, it's mandatory to have a PCR maximum 2 days before the anesthesia. But from the surgeon point of view, there is no really changes since COVID. No.
Manish, same question for you. Are you doing anything different surgically for these patients?
No, I think I totally agree with what Jean-Francois said. We do the same. As a surgeon, I'm not doing anything differently. I'm wearing the same masks, the same gowns, everything is disposable. However, there are some practices across India which were doing different sorts of non-disposable re-sterilizing things, which have had to change these practices. But since we were doing it, we've not made a major change. And the only change is for GAs, and especially where anesthetist needs to wear a full PPE. For the locals also, the anesthetist does have a shield and the extra gear. The only other thing we do is when the patient is lying down, and we used to have that breathable, disposable material on top of their face going on the nose. Now we keep an offside and make sure there is an oxygen supply going in from below, but we keep an offside so that there is no connection between the surgeon's breathing area and the patient's, just in case the patient coughs or sneezes or something like that. So apart from that, I don't think we are doing anything different.
And Maria, you're an advocate for 3D heads-up surgery. Do you think that decreases the potential risk for surgeons in this COVID era?
Well, I think it does, because you're really not as close to the patient as as you know, with a conventional microscope. The other thing that we're doing differently, all the patients come in with a mask, so I tape the mask on the patient, their own mask. So, or, you know, we usually put an OR mask just so that air doesn't come in, and they put a suction also under the drape to suck away all of the breathing. And the 3D is very helpful, but I also wear an N95 with a surgical mask on top myself. But I do not wear PPE. I do not wear a shield because that would interfere with my vision, especially with the 3D. But that said, you know, the one concern that I do have is, you know, with patients' masks is basically their breath coming over towards the eyes in post-op patients. You know, that is a thing that I have in the back of my mind as far as endophthalmitis and the possibility of that, which I haven't seen any cases, but it's something that sort of worries me somewhat, you know, because most patients wear the masks improperly. It's not really fitted over here. And just like it fogs when you're examining them, you know, your lens fogs as you're seeing them, all that, or if I'm doing a laser or examining them, what I do is I tape it down so that doesn't happen, but it concerns me when they go home with their masks and all that breath with potential bacteria goes up into the surgical eye.
And you do that as well for injections?
I don't tape it for injections, but I hold it down, you know, I hold it down as I'm injecting.
Yeah, because I personally worry about that with injections. At first, I thought this was going to be great for injections, patients wearing masks, until you see these ill-fitting masks that just the air from the breath blows straight up into the eyes. And actually, I found on those rare patients that I use the 90 on when I need to look at the slit lamp, you have to take their mask down because otherwise it will fog your 90 diopter lens and you just cannot get a good view. Maria, telemedicine. Are you using any telemedicine, any telehealth?
Yes, I am. I don't have, my patients are all elderly, so they really are not key in using a computer, but I do a lot of phone telehealth with patients. You know, they send me pictures with their phone. Let's say their eye is red or post-op, if they have a question, oh, my lid is swollen or whatever. I said, send me a picture. So I do a lot of that. I would say that every day I call back maybe 2 or 3 patients for questions like that. Instead of in the past, you know, many of them would be coming in. But now they're getting used to that, and I think it's very efficient, actually.
Jean-Francois, telehealth in France, is it being widely adopted? Are you using it for your patients?
No, I'm not using it. We tried, and quite quickly we found that the answers are not clear enough so that we can have a clear view on the situation. Some of them will say, I'm okay, and they do not realize that something is going on because they do not patch the other eye. Some of them are saying they have a lot of pain, and when we tell them to come, in fact, they have just minimal punctuate keratitis. So we found it's extremely difficult to evaluate the situation by phone. So we stopped doing that, yeah. Some of my colleagues are calling the patients, instead of asking the patient to come back the next day after surgery or 1 week after surgery, they replace that by a call. And if there is no pain, if the vision is clear, then they will say, okay, let's see just 1 month post-op, and that's all. So in post-op situation, maybe you can avoid 1 visit to the clinic by giving a phone call. But for all the chronic patients, AMD, diabetic patients, etc., we found it was not very efficient and not very safe.
Manish, same in India. Are you using telemedicine? Is it being utilized routinely?
No, not in a big way. The only telemedicine you could say is when a patient cannot come to us straight away and has gone to a local doctor and has a report, and he WhatsApps us or messages the report, and then we can guide them related to the severity or urgency. But it's limited to that, not about directly trying to get pictures of the eye. Patients can't get access to that, so it's very difficult to understand what the problem is unless an eye surgeon has seen them.
And I just want to take a few minutes here to talk about future technologies. And these technologies may or may not be here during the COVID-19 pandemic, but hopefully they won't be. I mean, the pandemic is over. But let's talk about two things in particular. Number one is home OCT, and number two is port delivery system, an extended drug delivery system that requires surgical implementation, which we just received the data on the phase 3 study at ASRS. Manish, how will these two things change your practice, either in the COVID environment or the non-COVID environment?
Well, it makes sense if we have access to an OCT picture of an eye, we can derive information out of it and can understand is there any new change in that from what was there before, and would be useful for sure. And as far as the port delivery, again, because it's a sustained long-term delivery, it's preferred because patient doesn't have to come back so often, and you have the drug going in for a longer period. And I'm sure if this works, this will be great for post-COVID as well. Only thing is it all amounts to what kind of cost effectivity it would have. In India, we have economics are different, and it does have a role to play. So it would be based on how it's available commercially for the patients in the long run.
Jean-Francois, same question. Home OCT and port delivery system. How do those two things fit in during this time and in the future?
Well, first, I've seen a demo for the home OCT, and it's really impressive. It's really easy to have a scan, and you have the artificial intelligence comparing with the previous exam and detecting if there is anything new or not. So the technology is available. But I like very much a proactive treatment to treat before the recurrence. So I think that as long as we use drugs, we don't need home OCT. We just try to extend, and we need to control with an OCT. And I don't like to wait for the recurrence to come, because some of the recurrences are really bad, and we lose vision, and that vision loss is not going to come back. But for the port delivery system, it's a different story. We've seen in the studies that some patients, the drug is there, and the benefit of the drug is there for 4 or 5 months, but some of them last 12, maybe more. So for the port delivery system with the home OCT, I think it's a perfect fit for patients to avoid many, many visits. Then there is a coverage issue, of course, the money issue. How do we cover that? How do we fund that? It should be somehow associated. We should have this kind of bundle with the PDS plus the home OCT system.
That's brilliant. I've not thought about that, but you're absolutely right. Those things are so complementary. Maria, home OCT, port delivery, how will those fit into your treatment of patients?
Well, the home OCT is a great technology, but I think, my patient population is generally poor. So I don't see that as being a big player, moving forward in my patients. But the port delivery system, I'm actually very excited about. I think that is really the way to go, especially, it's only been for AMD, but for younger patients that will need injections for many, many years, and maybe for diabetics, I think it will be fabulous, because then you will feel safer treating someone that has proliferative disease or pre-proliferative disease with anti-VEGFs. I think that would, prevent progression really nicely. So I'm actually really excited about that. But of course, I have a surgical bias.
Absolutely. I think that we all do, for sure. I want to just take a second to thank Manish, Jean-Francois, and Maria for joining us on this episode of New Retina Radio, COVID-19 coverage back to practice. Thank you guys for joining us. Stay safe and tune in the next couple of weeks for our next episode.
Back to Practice has been made possible with support from Allergan and Novartis. We'd like to thank our sponsors for their support of this programming. This webcast podcast is intended solely for ophthalmic healthcare professionals and ophthalmic industry representatives. By accessing this webcast podcast, I acknowledge that Bryn Mawr Communications LLC, herein BMC, along with any all third-party corporate supporters of this webcast podcast, makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information presented in this webcast podcast. BMC, along with any all third-party corporate supporters of this webcast podcast, do not endorse, approve, recommend, or certify any of the opinions or information presented or mentioned. BMC expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or other damages arising out of any individual's use of, reference to, reliance on in this webcast podcast.